Assalamu alaikum warahmatullahi wabarakatuh. I'm Muhyiddin Mirza, your host for the program Food for Thought. I hope you have been following our program lately on a lot of interesting subjects. Our most populars have been up to now diabetes. We just made some program on Alzheimer. Today we are going to focus on arthritis, and we are very fortunate that a very premier, I call it, rheumatologist, Dr. Stephanie Keeling from University of Alberta has been able to join us. We will talk to her on about the disease, what are the symptoms, what are the causes, how could be managed, what are the new research direction as well. So let's talk to Dr. Keeling, and hopefully we'll learn a lot of good things. Dr. Keeling, really appreciate you're able to find some time for us. Tell us a little bit about yourself, that you are a rheumatologist. That's the term you like to use?
Yes, that's what I am. I'm trained as a general internist and then did 2 years extra training in rheumatology.
Right, right. Yes. So that is the disease we're going to talk about. So when did you get interested specifically being a medical doctor and then going into this sort of things?
I think I always wanted to be a doctor since I was 3 years old and received my first Fisher-Price medical kit.
Oh, right.
And my father is a family physician.
Okay,
and then over time I wanted to be a general internist because I liked, I wasn't much with my hands, but more trying to use my head. And then I rotated with some excellent colleagues here at the University of Alberta and realized that the immune system and arthritis, which are very intertwined, is what I wanted to do.
Yeah, and we'll like to talk about, but you made a very interesting comment that the childhood, you could see those children, you know, when they're 3 years old, they have all those stethoscope and those Fisher-Price ties, and they love to go. And I know my grandson used to do that, but he's gone more into karate and judo now, but he will took my heart. And yeah, very interesting. This is how you develop.
Yes.
So tell us a little bit that when we say arthritis, what is the disease? How do you describe it?
Arthritis, if you actually break it down, itis means inflammation of something, and arthritis is, I guess, Latin or Greek for joint. And so inflammation of the joint is arthritis.
Right.
But there's actually over 100 types of arthritis, and some people don't realize there's so many. I think the most common known arthritis is osteoarthritis, where your cartilage starts to break down as you get older, and over time you hear about people getting knee replacements or hip replacements. But you can have a habit in smaller joints like your hands and your feet. And then there's other types of arthritis that are more because of the immune system deciding to attack the joint. And the most common there would be rheumatoid arthritis. And then there's similar types of arthritis such as psoriatic arthritis. People with inflammatory bowel diseases can also have arthritis. You can have inflammation in your spine, so a condition called ankylosing spondylitis. You notice itis keeps coming up.
That's right,
And then there's other conditions where, for example, lupus, where the joints can also be affected to develop arthritis as well.
So you brought the terminology immune system, because we'll be talking about autoimmune attacking our own system. So tell us that for a layman, I know that so many things in the body are so automatic. I know what the immune system is, but describing it, I have no control over it. So why does it attack certain people, certain portion, and there's so many autoimmune diseases. So what is an immune system in a human being?
So the immune system was something that developed over time and was meant naturally to fight anything we get exposed to in the environment. So typically when we get sick, our immune system turns on and recognizes that perhaps someone has a bacteria or a virus. And so it's your body's natural defense to send little tiny white blood cells, and there's a lot of different types of those, and teeny tiny proteins that all communicate with each other. They basically, you can imagine it like an army going to attack whatever we call pathogens, so whether it's a bacteria or virus or other, and go and actually eat it away, fight it off. It's almost like your body's natural antibiotic. And you know, and then what's amazing is once you've had an exposure to an illness, your immune system is very intelligent. So it develops a memory to that particular bug that you had. And if you have another exposure, then most of the time your body has more natural defense, so it can fight it. And that's actually why we get vaccines, because it's based on the same principle.
But when you say immune system, it's not one organ. It is multiple organs are involved in doing this white blood cell, killer cell, T4 cell.
Yes, I mean, it's the immune system really is involved in all the different organs in your body.
Right.
And so, for example, you could imagine that different organs might be different stations for the different types of cells. You know, sometimes when you're sick, you feel lymph nodes and you feel they're swollen. And those little lymph nodes are actually little centers where the immune cells may suddenly develop because they know there's an infection brewing. Other organs, for example, your actual whole intestinal tract has lots of sites where immune cells can get active to fight infection. And the blood carries the immune cells to different places. So the immune cells are pretty much everywhere, and depending on what someone might be fighting, meaning whatever infection, they may concentrate in certain areas.
So it's not one organ that here is your immune, it's secreting everything, but a lot of organs are involved which could release the antibodies, whatever antibiotics are to fight those infections. Am I right?
You're correct. I mean, there's certain ones that are involved in the development of these cells. So your actual bone marrow, so deep in your bones where all your blood cells are made, you need to have a healthy bone marrow to do that. In our neck, there's a gland called the thymus gland, and that gets smaller as you get older. But when you're actually growing in your mother's stomach and then you are born in a young child, that's a very important place for your body's immune system to develop, all the lymph nodes, and so there are certain important stations, but they can go elsewhere because of the blood.
Right. So this is what you're saying, immune system is very complex, of course.
Yes.
And white blood cell is the common terminology people use, but you were saying that within white blood cell, I was reading T4 cells, killer cells, so many other cells are formed to do what? I mean, to suit to the who is attacking, what type of thing is attacking? Yes,
that's true. So as you mentioned, your body has a certain natural, what we call innate immunity, which means it's your first line of defense. So if you get a cold, so you have a virus, your body quickly sends out sort of like the first part of the army to sort of work on it. But these other types of cells, which is called your adaptive immunity, so things like the T cells and there's B cells as well, they're the ones that if they see a particular bacteria or virus, then they
don't have eyes.
No. If they sense, however you like to say, you know, if they see it, what they do is they develop a particular memory for that particular bug, and so you have what they call many different lines of T4 cells and natural killer cells, B cells, which make antibodies that fight certain types of bugs. And so certain cells are more specific to viruses, some are more to bacteria, some are more to other more exotic things, but still that you might get, like fungus or parasite infections too.
And this immune system develops right from when the child is in mother's womb and then slowly matures. Is there any stage, can we say, that is more mature in me rather than a child?
Yes. Yeah, and part of that is first of all, when a baby is in utero, they do develop natural antibodies that pass through the placenta. So when they're first born, before their own immune system starts to really produce their own immunity, they get some of the mother's natural antibodies, as well as through breast milk as well. And then over the first years of life, their body starts recognizing, you know, what we call foreign, so bacteria and viruses, and what we call, I guess, innate or of their own. Because if the immune system didn't get smart in your first years, it will start attacking parts of you, and that's the whole issue of autoimmunity, which is what arthritis leads to.
Could you tell us again that the immune system, which has been working in harmony with me and everything proper, suddenly it starts attacking my own organs?
Correct.
That's autoimmune diseases and arthritis. Some of the arthritis are in that category.
Correct.
So any idea why or what would trigger, or any causes known for this kind of things?
It's a very focused area of research right now. It is complicated, and I mean, you're correct that other diseases like multiple sclerosis are autoimmune, the different inflammatory bowel diseases, and it's not all, but a large percentage of the types of arthritis. And so when you ask about risk factors for arthritis, you know, we do think there is a genetic component. So not for everybody, but we do see in our clinics sometimes multiple generations of families with, for example, rheumatoid arthritis, above and beyond what you would expect. And so we know genetics plays a role. So if someone has the right genetic background, and that genetics means how their own immune system was designed basically,
right, yeah.
and then they get exposed to something in the environment, and that's a question mark. We don't know, is it specifically again a bug, some kind of bacteria or virus that we can't test for, or is it even other environmental things? You know, people talk about ultraviolet radiation and so forth, and perhaps increased toxins in the environment. So whatever it is, it's the right mix of genetics and the environment that seems to suddenly change the functioning of the immune system, and so it suddenly decides that parts of you it doesn't like. And so in the joints, there's certain linings of the joints. In rheumatoid arthritis, it's called the synovium, rather than the cartilage.
Synovium is a fluid, or is it a synovium is a fluid, or is it part of cartilage? Or so I mean, when you look at the bones, like knee, for example, like this, so is that the fluid inside, or is it the cartilage itself? Or
so the way the joint normally is structured is you have, for example, in your leg bone, your femur and your tibia, and they, you know, nature wants you to be able to have a nice smooth surface so they can bend. So they have a cartilage on each of the two communicating parts, and the whole joint is encapsulated with what we call a capsule. Inside that capsule, though, there is free fluid, which is your synovial fluid, and on the sides of the joint, just on the sides, is a little tissue layer called synovium. That keeps the joint healthy. It gives it oxygen, takes away waste products. And so in rheumatoid arthritis, the immune system decides it doesn't like the synovium, so it starts sending off more
just like
cells.
That, it doesn't like.
I mean, there's a lot of research as to what specifically at the molecular level might be there. But again, we're not clear as it all, in some people maybe genetics is more important, or that the immune system thinks that part of the joint looks like a bacteria, for example. So that's one theory. And so it gets confused, and it believes it is not, it's not part, it shouldn't be there, and so it starts to attack it.
So what you're telling me that well, we'll talk a little bit more on the research and medication. So sometimes the principle is suppress your immune system because we don't know yet why it's triggering.
For some of the diseases like rheumatoid and psoriatic arthritis and so on, yes.
So let's go back to a little bit the type of arthritis. Of course, rheumatoid is the inflammatory type. And rheumatoid could be anywhere, you know, here on the joints. Any joints could be attacked, small or big.
Yeah, it tends to start in smaller joints, we say, like your knuckles of your hands or these joints, and wrists and the feet. So a lot of people wake up in the morning and they develop long periods of stiffness, not just 5-10 minutes. We all might get a little stiff as we get older, but this is a stiffness that's very uncomfortable, and you know, in a 20-year-old is not expected. And over time, though, it can also involve larger joints. More commonly, it's smaller. It tends to be more than 4 joints, and it's usually on both sides of the body.
And you made a very interesting comment that mostly inflammations happen at night time when you sleep. When you get up in the morning, why is that? Is that the blood flow is reduced, or any ideas? That I have seen this myself as well, that my wife has the history, and it's mostly in the morning, and then you get up and try to relax. Is that possible that because blood is not flowing, or why is happen mostly at night time you sleep, early in the morning, and then get a little better when you
get going?
There
is there is variation to how much fluid is in your joints. Like even our hormone system fluctuates with night and day, and so similarly, we believe that once you get going and start standing up, you're able to, like, the natural pressures in your joint will mobilize some of that fluid that perhaps accumulated at night because you weren't moving around, and that also indirectly will get some of the teeny tiny proteins of inflammation that kind of accumulate over the nighttime to start at least moving. We do think that the hormones indirectly may also play a role, and we know there's that variation with them as well.
You did use a term, free radical toxins which accumulate in the body. What are those? What are the, if somebody wants to understand, I know in the media many times research free radicals. What does happen at cell level? I heard the term the other day that human body could consist of 100 trillion cells or 75 trillion.
Probably.
They're all together. So each cell has to be given food, oxygen, vitamin, minerals. They have to be supplied to those cells for proper functioning. So what does happen in that case is that if those are not supplied, are those reverse process of free radicals toxins are produced, they have to be detoxified, taken away.
And naturally, that's what happens, is that basically your red blood cells, they get oxygen from your lungs, and they go on, they circulate through everywhere, including your joints. And so they deliver the oxygen, and then naturally carbon dioxide, which is our waste product from all our cells, flows into the red blood cells, as well as, you know, various other, what you mentioned, like toxins, free radicals, and the body has natural chemical ways to absorb anything it doesn't want to stay around, which can cause damage to the cell. So then the red blood cell then goes off in the blood vessels, goes back to the lung, where you breathe off the carbon dioxide and then accumulate more as you inhale and take more oxygen in. And down to the joint level, that's what you need as well.
So rheumatoid, of course, and then osteoarthritis, you mentioned a little bit.
Yes.
So osteo is also progressive as you get older. Does it get worse?
Yes, so osteoarthritis may still have the immune system involved, but it's not as clear. And in that case, it's not the synovium, it's the cartilage that can develop and start to damage. It basically dries out, starts to crack, and you know, you can't stop walking. So for larger joints like your knees and your hips, there's continued stress on the joint, which eventually thins out the cartilage, and then once you have bone rubbing on bone, that's very painful. Now, there are risk factors for osteoarthritis. If you've ever injured a joint, particularly knees, we hear about lots of sports injuries. That joint is more vulnerable to osteoarthritis because it's not mechanically running quite the same.
Exactly, that's right.
Yeah, and you know, there are also, we do think that females and males are slightly different. Females tend to have their osteoarthritis come on more aggressively after menopause. So we do think estrogen protects women, whereas men, it can start earlier. But you can also have, you might see people with lumpy, bumpy fingers.
Exactly,
And that can be the same thing occurring in the larger joints, can occur in the hands as well.
Is that the most rheumatoid when your joints get swell here, or is it osteo?
Well, it can be both, but for different reasons. So you tend to have more bony enlargement with osteoarthritis. But if it's kind of boggy and soft, you worry more about rheumatoid arthritis. And again, in osteoarthritis, it's more that you might get new bone forming around these joints. It's almost like nature's way to try to rebalance a joint that's a bit, because of the cartilage being worn away, it's not quite as stable.
And you also mentioned lupus.
Yes.
So what is lupus? I've heard this term, but is it a type of arthritis?
Lupus is actually, it has arthritis as one possible feature. It is an autoimmune disease where, again, we don't know exactly the cause, but we think genetics and the environment together are important, where the immune system can attack different organs. So some people, not everybody has the same, I guess, number of manifestations, but essentially your skin can have funny rashes, you can get sores in the mouth, lose a lot of hair. It can be cosmetically very unpleasant. You can have a rheumatoid-like arthritis, so you get pain and stiffness and swelling in similar joints to rheumatoid, but it can also unfortunately affect large organs like your lungs or your kidneys and lead to kidney failure or lung hemorrhage.
Lungs as well.
Yeah. And it does tend to happen more commonly in females versus males in their 20s, 30s. And obviously it will affect then childbearing potential, and you can still have children, but if it's active, it's more complicated.
You also refer to psoriatic arthritis.
Yes.
So is that skin problems getting into arthritis?
What they've found is maybe 20% or higher of people with psoriasis, which is a scaling skin condition, that, you know, can also be quite uncomfortable, and people have a lot of their body surface area covered in psoriasis. They don't like how they look. People think they have a contagious disease, and it's very unpleasant. But about 20% have inflammation in the joints. So similar to rheumatoid arthritis, it can affect the joints exactly in the same distribution. Sometimes it can cause inflammation in the back. Sometimes it can cause, you know, a lot of nail damage, and these joints here can be involved. And sometimes it's just one or two, but when you have a large swollen knee, it's hard to do anything.
And then you also mentioned that things like inflammatory diseases in the ulcerative colitis or Crohn's disease, they could also change into arthritis? You're saying that
we do find that people with inflammatory bowel disease, whether ulcerative colitis or Crohn's, a certain percentage, and it varies what you read, maybe a quarter, maybe less, can have inflammation in the joints that may look similar to rheumatoid
Right,
arthritis.
right, right.
Sometimes it goes along with, if their bowel disease is active, their
Right.
joints are active.
Right.
And often when you treat the bowel disease with medications,
Right.
or even sometimes corrective surgery, the joints get better.
Right.
Sometimes, however, they also have the type of inflammation in the back,
Right.
which is also known as ankylosing spondylitis.
Right.
And sometimes they also, their joints are inflamed, but they don't
Yeah.
go with their bowel
Right,
disease.
right. That's great. So we talked a little bit on the causes and risk factors. Of course, you mentioned genetics is a possibility. Does food habits has to do, and I mean, when you say statistically, have you seen that people coming from India, Pakistan, or South Asia are less susceptible, more susceptible? What's your take on this type of observation? In your own practice, for example, do you see?
Very common question, you know, and people want to know, you know, none of us love medications.
Right.
So if we have natural ways or food ways to
Right,
control disease,
right,
why wouldn't we try them?
Yeah, exactly.
You know, there are lots of different types of arthritis, and in general, I think of all the types, one that we actually didn't mention was where food is probably most important is gout. So
yes, that's true. Yeah.
and so in very briefly, gout is where you have too much of a protein called uric acid, and that's where food comes in, because if you eat too much heavy foods, shellfish, red meats, organ meats, exactly.
Things with purines.
Anything with purines. Those are, they can lead to triggers, or they can lead to too much uric acid, which gets into the joints. The body sees it, tries to eat it up, and that triggers very, very red, hot, painful, swollen joints.
I have suffered that for, now I have learned to manage it with some medication and without. Food is a big role played in that kind of arthritis.
Yes. You know, for the other types of arthritis, we really, you know, some people swear that certain things lead to or improve or make it worse. And I've never denied someone from following what they've experimented with on their own. I think most of us, there's not a direct link as a cause of food to arthritis, though. But we do recommend eating healthy foods. You know, follow, I guess, if you like the Canadian Food Guide, or, you know, similar healthy, kind of heart-healthy diet. Because we do know that a lot of the inflammatory arthritis diseases, like rheumatoid arthritis, means your risk of heart attack and stroke is actually higher. It's similar to maybe someone with diabetes. So you want to eat healthy because you want to keep a healthy heart anyway. Right,
yeah. So going a little bit into research direction, what's going on? I know this is the arthritis month of the Arthritis Society. They're promoting it a lot. So what directions are taking place beside medication, of course? Are we autoimmune studies going on? So what type of research is in the forefront right now?
Well, I think, I mean, briefly, although we could talk for hours about medication, there's a huge shift in treatment of inflammatory rheumatic diseases like rheumatoid and psoriatic arthritis because of these new category of drugs called biologics, which essentially are, they're very expensive medications, but most provinces and countries now have ability to cover them. And they block the certain teeny tiny proteins that are very important in inflammation. And so there's lots of those proteins, so there's lots of different medications that are in different stages of clinical trials and research to see if blocking this protein, for example, leads to overall improvement in all of the symptoms and stop the joint damage progression, which leads to disability. Other than that, you know, there's lots of research looking at what are the causes of arthritis. A lot of times they do have to do animal studies to prove that. And so that continues. A lot of genetic studies are going on looking at specific genes or combination of genes. And then there's a lot of work being done in different provinces at how arthritis affects the workplace. And that's a huge, that's actually the theme. I'm glad you brought this
point, because this was one question that the psychological effect, the workplace. So what's your observation on that?
Well, if you look at Canada, we have 4 million Canadians with arthritis. That includes all the different types. And 60% of those are in the working age. And yet, you know, some types of arthritis are worse than others. But they all, in general, are associated with pain, stiffness, and changes in your function. And so if there's $6.4 billion a year Canada is spending on arthritis, and a lot of that's long-term disability. So the work is into trying to figure out how do we keep people at work. And a lot of that means targeting your employer. So that means, you know, a lot of people don't like to disclose they have arthritis. And we, you know, we all have pride and it's our personal business. However, a recent poll of Canadians said that 500 Canadians thought that people with arthritis, 40% of them said, we don't think that a person with arthritis has any less ability to work at our capacity. So that's a significant misunderstanding. And so if your co-workers were able to understand and not feel that you're not working hard enough, you know, that's important. If you have a conscientious employer who is able to say, I'm going to give you a flexible work schedule, perhaps you may not work quite as long and you have more breaks. We talk about pacing someone or allowing flexibility that you go into work when you're less stiff and sore. Maybe you can work from home.
And you're so right that I have worked in the government system for 30 years and all things have changed quite a bit now. Workplace exercise, they brought in people for education and seminars and sometime yoga and all those things are happening, and that's a good sign. Even I know Alberta government came out that will give you $500 a year if you go and exercise more and even buy a good computer for research. So I think they're becoming quite generous in understanding that if the population is getting sick and this kind of problem, and those are the people who are going to work.
Yes, no, and then this is true. You know, they talk about even just whether if you're a physical laborer, then you may have to modify your duties or perhaps learn to go to work, train back to something different. If you're sitting at a desk, you know, even having a keyboard that's split so you don't strain rather than like that. Just simple things, or a stool to keep your legs in a more neutral position to less strain on the knees and the hips. And a lot of times occupational therapy is very important in helping assessing that, and physiotherapy to work on exercise as well.
A little bit on the medication which are commonly used. I mean, you are not going to make a prescription, but our readers our listeners want to know at least that there's a progression of medication. Let's say somebody come to you and you diagnose after all the medical tests that it is a rheumatoid arthritis, for example. So your first treatment strategy will be going into non-steroidal anti-inflammatory type drugs. Is that painkillers, or what will be the first approach you take?
Well, it used to be that that was the approach, painkillers, and then the more severe the disease appeared, we would target with more immunosuppressants. Now we've sort of shifted where we feel that we need to try to decrease the activity of the immune system, but not at the expense that you get too many illnesses. And so now what we do is we try to diagnose early. So someone has fewer joints and fewer symptoms, and the family doctors have been educated to try to refer more quickly. They may initially, when someone's having pain, at least start an anti-inflammatory, as you mentioned, or Tylenol. And then quickly, we like to start what we call disease-modifying anti-rheumatic drugs, which essentially means immunosuppressants.
Oh, I see.
And this is where there's a lot more new medications, the biologics as well. So the list is quite huge now in the past 10 to 15 years compared to, say, 2 or 3 previously. And we choose those based on how many joints someone may have that are affected. There are certain blood tests that show more inflammation, and if so, and if they feel terrible if they're off work, we will use stronger medications.
Quick comment, what do you see in future that more drugs, better management is coming, more knowledge is coming? I know you go on global TV and give a 3-minute spiel on a weekly basis. What do you feel when people are asking you questions? Do they want to know what's the future direction? Better medicines are coming?
Well, I think we try to tell people better medicines are coming, but they are always tempered by the fact that the long-term data that we want. You know, we know that there's no cure yet for arthritis. So for rheumatoid arthritis, these medications are fantastic. We've seen amazing things. We don't know if there's side effects that are unclear for some of the newer ones until we have more, you know, 10, 20 years of data. So far, things look good, though.
We only 1 minute left on Arthritis Society of Alberta and Northwestern Territory, whatever. So they have a good website, good information is there. I have browsed through it. So you would recommend our listeners to go through and see what's there and ask more questions?
Yeah, and if there, you know, we also have the Tylenol Walk with the Arthritis Society on May 15th, 2011. Multiple sites across Canada to raise money for all types of arthritis.
Thank you very much.
My pleasure.
I appreciate your time.
Thank you.
Well, this is program Food for Thought. I'm Mohidin Mirza. You have been listening to Dr. Stephanie Keeling, is the Assistant Professor of Rheumatology in the University of Alberta. Hopefully you got some good information on basics of arthritis. Our purpose was not to give you too much information, but the idea that the disease can be managed if there's an early diagnostic done, better medicines are coming in, and some responsibilities yours as well. Keeping your health, for example, by eating good food and avoiding stresses in life as well. So hopefully this has been a good information for you. Please do email us, do write us what more information you might need. Thank you again. This is Food for Thought. I'm your host, Mohiuddin Mirza. Assalamu alaikum wa rahmatullahi wa barakatuh.